welcome to another episode of Keeping London Healthy. My name is Dr. Elia. We've got an interesting episode for you today, a topic that is often ignored, often pushed to the places that we don't talk about. And today we're bringing it to the forefront, and we're talking about a bit of an embarrassing topic for many of you. We're talking about erectile dysfunction today. So what I would advise is that if you've been struggling with erectile dysfunction and haven't wanted to speak to your doctor or whoever you look to for care, today is the episode where we're going to talk about all the issues you need to know about to then bring to your own doctor. If you know someone with erectile dysfunction, this is a good episode to hit record on the PVR. And maybe when they're walking into the room, you can press play and voila, there's the episode on erectile dysfunction, because it is a topic that, understandably, people don't want to talk about, but there are things we can do as doctors. There's treatments available. We're going to talk about all this exciting stuff today. And to help us today, we're going to be bringing in Dr. Jeffrey Campbell, who is a urologist here in London at LHSC. He's in the Department of Surgery in the Division of Urology, and he deals with mainly erectile dysfunction in his practice. So he's a great guy to bring on the show today, and he's going to answer all our questions about erectile dysfunction. I'm going to take a quick break, and right after this message, we'll bring in Dr. Campbell. All right, welcome back. Again, we're pleased to be joined today by Dr. Jeff Campbell. He's a urologist here in London in the Department of Surgery in the Division of Urology. And again, we're talking about erectile dysfunction today. So I'll paint a picture, in our office. Inevitably, we get a call from somebody, and it's often a mysterious phone call where the patient will tell the staff, "I just need to talk to the doc about a private issue." And I'll tell all you patients, when we hear this, we know exactly why you're calling. So you don't have, our staff have heard this a million times, so there doesn't have to be any mystery around this. And we get these calls probably a half dozen times a week in our office. Obviously, Dr. Campbell sees this much more frequently. But we want to kind of remove a lot of the shroud of mystery around this, because we do see this so frequently, and it is something that's often ignored or pushed to the side. Men are often kind of embarrassed to talk about it, but when we actually can talk about it, deal with it, it inevitably improves someone's quality of life. So Dr. Campbell, thanks for joining us again. So I guess the first question I'll ask is if you can kind of paint the picture of, we won't get into a long physiology lesson here, but in someone who is presenting for the first time with erectile dysfunction, they're kind of wondering, what's happening to me? Why is this happening? What's kind of a simple explanation as to why they might be experiencing this change in the quality of their erections?
So that is definitely a loaded question. And when men present with erectile dysfunction, I usually try to rule out some of obviously the main things that could be dangerous. But it's always multifactorial. So in order to get a good normal erection that can last long enough for intercourse, you need good blood flow, you need good nerves, you need normal hormones, you need the psychological aspect in terms of arousal, and then you need normal anatomy. And so really it's kind of trying to figure out which one of those things could be affected, and often it's more than one.
As you said, there's lots of different causes. So the average, let's say 50 to 60-year-old man coming in the office, first presentation, might have a bit of hypertension, might have a bit of cholesterol issues. What would you say that would be the kind of a major cause in that kind of gentleman? Again, some exceptions here and there, but kind of the most common cause in that guy.
So the most common cause for erectile dysfunction in that age group would be related to the blood flow, so arterial inflow. And as we know, the penis has blood vessels that go through it. In order to allow for erection, they need an inflow of the blood flow. But the blood vessels are relatively small when you think about the blood vessels in the rest of the body. And so if those blood vessels don't expand and dilate just like everywhere else, then it will affect the erectile function. And often those are the first blood vessels to get impaired when men do have issues with arterial function.
A quick aside, just so we don't forget, one thing that is often missed, I guess from the patient standpoint, but the physicians can't forget this, is that when someone's presenting with erectile dysfunction, especially kind of middle age, that is often a clue of other vascular risk factors going on. So if you are, let's say you are someone with erectile dysfunction and you don't want to see your doctor and you don't want to treat it and just want to ignore it, totally your call, but there may actually be underlying issues going on here that you may want to speak to your doctor about. So making sure you get your blood pressure checked, get your sugars checked, get your cholesterol checked, because the penis is often a window to the heart, in that there might be some early plaque that we can do something about, and that could be an early sign of something that may lead to a heart attack down the road. So just again, if not interested in treatment for erectile dysfunction, totally your call as a patient. But again, we don't want to ignore that, and we actually do want to hear that as physicians. So the majority of these patients are being seen in primary care. So this is the one thing I can tell patients is that when you come to see your doctor, the vast majority of you will be able to be dealt with by your family doctor. Investigations, treatments, and Dr. Campbell obviously sees a subset of those who either the family doctor is not comfortable treating or kind of more severe. What kind of questions? So let's say, we'll make you the family doctor, Dr. Campbell. But even in your clinic, what kind of questions are you asking these men in terms of their erections that will help you kind of tease out what exactly is going on?
Some key factors really is the issue getting an erection or maintaining it. So some men can get an erection and it's great, but it only lasts about 30 seconds and it goes away. Is this been a sudden change? So did you, last week, no problem, and then today and there forward, it's a problem? Or has it been a slow progressive decline over the last couple of years, which would obviously kind of be more along the vascular stuff that we were just talking about? And you also want to know, has there been any changes in either sexual practices or their day-to-day life, stress, new partners, new relationships, things that might give you clues that something else is maybe going on? And you just kind of want a general overview of neurological symptoms, numbness and tingling anywhere else in the body, any injuries that have occurred. And so kind of things that might lead you down, again, those kind of big differential things.
And you mentioned kind of the abrupt change. So if someone had completely fine erections and an abrupt change, what kind of things are you thinking about for those kind of patients?
Patients who've had a very abrupt change have either had an injury that's affecting the nerves, which is obviously pretty unlikely as an isolated event, or a lot of those patients have a bit more of kind of a psychological or stress-related response that is probably affecting things. You don't have a sudden change in your blood flow overnight, but you can have a sudden change in your mental status because of something else that's gone on, either a physical or mental trauma that could be affecting things as well.
In terms of investigation, so we've taken the history, we've asked the patient what's been going on. What kind of investigations typically are you ordering for? Let's first say the patient with kind of a gradual onset of this over time. What initial investigations are you ordering? What can someone expect?
So in a younger patient, in their 30s to 50s or 60s, who are having kind of new onset of erectile dysfunction or sudden change in erectile dysfunction, things that you do want to look for is the hormone profile. So you do want to check their testosterone levels. And you also do want to check things to rule out metabolic syndrome or, other conditions. So cholesterol, diabetes, hemoglobin A1C would be important in those patients for sure, because like you said, it could be an early sign of something bad going on. And so those would be kind of the screening blood work for most patients. In a standard, 65, 70-year-old guy that's starting to notice progressive decline, if he has normal sex drive, you don't necessarily need to order any blood work for those patients and just talk about, kind of the normal aging process and treatment options.
You mentioned testosterone. So obviously that's something, many men coming in with first onset of erectile dysfunction automatically go to testosterone as what they believe could be the cause of their symptoms. In someone with an otherwise normal libido, do you often see ED manifesting as testosterone deficiency manifesting as ED, or is that fairly uncommon?
Unlikely. And so you're exactly right. A lot of men blame their testosterone levels and want their testosterone checked and want to try being treated with it. But there's no good medical evidence to suggest treating yourself with testosterone will actually improve your erection. If you have erectile dysfunction and you're taking something like sildenafil or other medication, the testosterone might make you more responsive to it, but it's not going to fix your erections on its own.
Any role for imaging? I know some people ask, do they need to have their penis imaged or their pelvis imaged? obviously in primary care, we're not doing much of that in your role as a specialist, and any role for imaging that for these patients?
For the run-of-the-mill patient, not usually. If there's a history of trauma or injury or something else that's going on, a change in the shape of the penis with something like Peroneus disease, which is also very common, then we will often get an ultrasound of the penis. They're only done in a few specialized centers, though, in the entire country. We do fortunately do them here in London, but the indications for that are kind of, something that's a bit more unusual, and we don't do it kind of as a routine practice. It shows what the blood flow is like.
And I want to make sure, you mentioned Peroneus, and I want to make sure we don't forget to get back to that. So we'll probably jump in right now. Can you talk a little bit about Peroneus? Because I know this is, we talk about things that are kind of taboo and men don't like to bring up. I think that's probably near the top of the list. So I think it's an important one to discuss. If you can just tell us a little bit what it is, kind of what treatment options are available for it.
Peroneus disease is a collagen disorder where basically there's a scar tissue that forms on the erectile tissue. And then this can affect erectile function in men. It can also affect penile shape, or can result in penile curvature, which is kind of the most common presenting symptom. And men can usually kind of feel a scar, something kind of different in their penis. It's actually very common. Men are very embarrassed because they often feel very self-conscious about it, but it's very common and very normal. It occurs up into 10% of men, so 1 in 10 is pretty common. With a small amount of curvature, there's not necessarily much that we need to do. If the curvature affects the ability to have good erections or have sexual activity, then we can talk about treatment. They've ranged in their invasiveness from something simple like wearing a traction device, which some guys will use for a period of time to try to correct some of that, to doing some injections, which needs to be done in a specialist office. We do a lot of that, obviously, in our day-to-day. Or some men do need to go and eventually get surgery to fix it as well.
I'm glad you brought it up, because it's something that patients often don't ask about, and I know there are newer options in terms of the injection. So for patients out there, if you bring it up to your family doc, make sure you ask, if you think it's severe enough that you want to treat it, ask to see that specialist, because some family docs may still not know about injection options for it. So just something to keep in mind. All right, we're going to take a quick break, and when we come back, we're going to talk about treatment of the average person with erectile dysfunction. Welcome back. Again, we're being joined today by Dr. Jeff Campbell. He's a urologist here at LHSC in the Department of Surgery and Division of Urology. So we've talked a bit about kind of the causes and some of the questions that a doc may ask you when you come in and mention that you've got some erectile dysfunction. So we'll get now to the kind of the meat of things, and sorry, no pun intended. So we're going to talk about treatment. So first, I guess we'll talk about non-drug treatments. So before we talk about, what prescriptions are available, what kind of things can men be doing non-medication wise to be improving their erections?
The first step for treating erectile dysfunction, especially in primary care, is really lifestyle modifications. Unfortunately, it's usually the same things you've probably been telling patients to correct their cardiovascular health, some patients for weight loss, etc. But really, all of these things are helpful for the penis as well. So anything that makes your heart healthy will also make your penis healthy. So really important, smoking cessation. So if you are a smoker and you want to preserve erectile function, you need to stop smoking. Weight loss, but more specifically exercise. So there's some good evidence to suggest that exercising at least 30 minutes a day, 5 days a week, will actually improve your erectile function, even outside of weight loss and all the other benefits you might get from exercise. But that exercise is going to pump your blood through your body, it's also going to pump it through your penis. So very important. And then obviously diet, and although there's no specific diet that is better for erections, a regularly balanced, healthy diet is going to be good for your overall health, and therefore also for the health of your penis. And then outside of those kind of common things, which again, I feel like patients get very sick of us telling you that you need to do that. But I mean, it's also kind of easier coming from me saying, if you want to help your penis, this is what you need to do. but there's also really good support for counseling or coaching or therapy related to sexual dysfunction. It's so common, and men think that having to see a therapist or seeing someone to talk about it is a sign of weakness, and it's really not, and it's really the first step. And I recommend it to every guy who comes in with erectile dysfunction as well.
Obviously, we counsel them about diet and exercise and kind of become broken records, but I can tell you, and patients will often attest to this, it's one thing to tell them to exercise to prevent a heart attack and stroke 20 years from now. When you tell them that they're having erectile dysfunction because of lack of exercise, that often gets them going a bit quicker than average. And again, quitting smoking too. Obviously, we've all had patients who quit smoking when you just lay out for them that it's actually causing or having some effect on their erectile dysfunction. Questions about alcohol and cannabis. Best evidence for that effect on erections?
Yeah, so it's a bit controversial. Excess alcohol or cannabis use definitely is going to worsen your erections. If you go out and you have too many drinks, most guys will find that they're not able to get an erection. There's some moderate evidence that might suggest, a drink might actually make the erections better, and that's probably because it affects the psychological aspects. So guys kind of get out of their own head when they're trying to have sex. They're not worried about their erections or worried about their performance, and so that's probably why it actually makes things better. But yeah, also diabetes. So if you are diabetic, making sure your sugars are well controlled, because again, just like you start to lose, sensation in your feet or your hands, or you start to lose your vision, you also start to lose the blood flow to your penis.
Move on to medications now. So first line medication for erectile dysfunction for most men will be a class called phosphodiesterase 5 inhibitors, so Cialis or Viagra. Can you tell us a little bit about how this class of medication works?
So these medications, their goal is really to help augment or improve the erection that you can get on your own. So if you can't get any erection on your own, it's unlikely that this medication is going to work. It also does not give you an erection. It just allows the erection you're getting to either last longer or to improve the blood flow a little bit more, so that it gets a little bit more firm and you can use it for intercourse. The medications are taken usually a couple of hours before you want an erection. Depending on what you're taking, you need to speak to your pharmacist, but certain medications need to be taken on an empty stomach because they're absorbed better. Other ones do not. And they can last usually anywhere between 12 and 24 hours, again, kind of depending on what you're taking. But they are not a magical pill. You still need to be built on, you still need arousal, and you still need to be intimate, and everything else needs to kind of build up to it, and it will just help improve that erection. And it does not work every time. Commonly, guys are very frustrated because they took it once, it did not work, and then they gave up. And it almost never works the first time because you have so much buildup and anxiety related to it that it's never going to be able to just be natural.
And side effects?
So the main side effects patients will complain about is headache is the big one. Some guys will get a bit of kind of blurred vision, back pain, muscle aches, some stuffiness. All of these are obviously temporary, and because the medication is just taken as a one-off, if you don't take it anymore, the side effect is gone. And it really comes down to, is the side effect worth the benefit? Some guys will also take these medications on a low dose daily. So with tadalafil specifically, because it lasts for about 24 hours, guys can take a very low dose daily. And so they always kind of have a little bit in their system, which allows for more spontaneous erections without having to think and plan when you're going to have sex. So that often works really well, especially for younger guys.
Deciding between Cialis and Viagra, some considerations there?
Yeah, so there's no benefit between one or the other in terms of how well they will work. For some people, one works better than others. So if a patient takes Viagra and it doesn't work, there's really no harm in trying Cialis, and vice versa. There's also other ones out there as well that they can try. And so the main difference really is Cialis lasts longer, so you need to take it further in advance of having sex. So I find it's better for guys who don't want to plan as much, that they could take it, in the afternoon, and then if they have sex 6 hours later, it's still in their system. And also that one does not need to be taken on an empty stomach, so you don't have to, again, plan it around meals. Versus Viagra, you have to take it about an hour before and on an empty stomach, which is sometimes tricky for people because a lot of guys want to have sex Friday night and they have, date night dinner and they have a full stomach, and it's not going to be absorbed the same. So that would be kind of, feeling out when they're going to use it would make kind of that difference.
So you're having men take Cialis a couple hours before they intend, at least a couple hours before?
Usually, yeah.
Yeah. And in terms of dose, so not the exact doses, but in terms of how we dose, typically, so I know the doses of Viagra specifically, whether you give a 25, a 50, or 100, roughly the same price. So
Yeah.
typically what I advise is we prescribe them the highest dose, because often people are paying out of pocket for this, then they can cut the pills. Do you often have them take the highest dose to start to get that confidence up, or do you start a lower dose? Typically, I've advised them to take a high dose and then kind of work their way down. What have you advised?
That is absolutely the best strategy, and I think that's not common practice, because same with most medication, people start low and move their way up. For erection medication, I always start at the max dose, because you want to know if it works. Most men, I mean, there's some anxiety related to taking these pills, and you're putting a lot of pressure on yourself. And if it doesn't work and you're titrating it up, it just builds up, and it's going to make it more and more difficult. And so I always start with the max dose. If it works, great. Then you start cutting the pill back, and it's easier to wean backwards to see, like, is half a pill as good as a full pill? Usually it will be. And then slowly work my way down as opposed to working my way up, because you kind of have one chance for success.
And I'm glad you mentioned the kind of daily Cialis. So again, for men out there, if you're having issues with signs of BPH, so some stream issues and some erectile issues, once a day Cialis is often a good option. So you may want to speak to your physician about that. And the thing that patients should know is that in terms of effectiveness of these medications, when we look at all the medications that we have in our armamentarium as physicians, antibiotics, stomach pills, I would hazard a guess, and the stats bear this out, that the phosphodiesterase 5 inhibitors, so Cialis and Viagra, above placebo, are probably the most effective medications in terms of how well they work above placebo. Number needed to treat, I think, of 2 above placebo. So they do work well in a lot of men. So again, if you're having issues, definitely worth having a conversation with your doctor about it. So if those don't work, which happens not infrequently, what's next for patients? What should they be asking about?
So if those don't work, then you should be coming to see me, and we have a bit more of kind of an in-depth conversation. Or, I mean, some people will kind of give up and say, you know what, I'm not really interested in anything more aggressive. If they don't work at all, then I would kind of also take a step backwards to those initial things we talked about, seeing a therapist or a coach or a counselor to kind of figure out why they don't work at all. Because unless you've had, some sort of injury or really severe erectile dysfunction, they should make some benefit. But if they do not, then there are lots of other options that usually I talk to patients about. Some easy stuff are things like vacuum erection devices. They can be bought online, over the counter at most sex stores. Patients will kind of put them on their penis and pump them up like a blood pressure cuff. Men can get little pills that they actually put in their urethra, and it secretes a medication that allows the dilation of the blood vessels. And then usually when I see patients, we're talking about things like injections. So we can teach you how to do injections into the side of your penis. It's a very small insulin needle. It sounds a lot scarier than it really is. And men build it up much worse until they do it once and realize it really doesn't hurt. But that delivers a medication directly to the penis that will give you an erection, with or without arousal, stimulation, etc. It's basically a chemically induced erection.
And I know obviously the needle kind of concerns around that, but I can tell you, in our practice too, we've got a number of patients who are doing the injections and are quite happy with it. And any role for penile implants? I know obviously we have some patients who fail kind of everything leading up to that. Penile implants an option here in town?
That we have the biggest, highest volume of penile implants in the country here in town. And so, yeah, that would be for guys who have failed other options and or not able to do other options for various reasons. Penile implant is basically an inflatable device that's inserted in the penis. It has silicone tubes that are in the erectile bodies, and then a pump that sits in between the testicles that men will inflate and deflate whenever they want to use it. There's really no going back once you have it in terms of, oh, I don't like this, I'm going to go back to Viagra. Can't really do that. But it's kind of the gold standard final step, and we do a ton of that in town.
And anything else exciting kind of locally that you guys are working on?
So there's a few new implant models that are coming down the pipeline, but probably not for several years. We just finished a study locally looking at actually using mindfulness as a form of therapy to treat erectile dysfunction, and that worked very well. We have some trained facilitators we work with, and so we're kind of looking at preventative causes, so men aren't having to get to the end stage, and kind of looking at ways to make things better earlier. which I guess limits business for me, but that's okay because it's better for patients.
Sounds great. Awesome. Well, thanks so much for joining us today, Dr. Campbell. Super helpful information, and hopefully everyone took at least some information from this that they can take and speak to their docs about.
All right. Thanks a lot for having me.
And again, thanks to Dr. Campbell for joining us and giving us all that useful information today. So again, as a reminder, if you or someone you know has erectile dysfunction and is open to getting some help for it, please reach out to your family doctor. There's things we can do. There's referrals we can make. There's medications we can try. There's things we can do to help. And you don't have to be suffering with this. So until next time, stay healthy.